And instead of, as was alluded to in the presentations earlier, programs have historically had a structure. This is our program, this is how it's structured, and this is what you do. And you stick to the program, and if you violate those terms, you may be discharged, right? Because you didn't comply with our program. Going forward, we have to have a more patient-centered approach, that we have a medical necessity determination, a treatment plan based on that determination, and then we reassess as time goes on with regard to treatment notes and that sort of thing, treatment plan updates, and we look at how the patient is doing as time goes on, and we adjust according to what their needs are. And harm reduction strategies should be a part of that. So if they're having difficulty and what we would traditionally call a harm reduction strategy helps them toward recovery, that's something that ought to be considered as a part of treatment. So I think I would look at that as a way of being more patient-centered. And I don't know if others have thoughts that they want to add about that.
So we feel really strongly that the treatment is healthcare. So in terms of whether it's a medical model or a social model, to me, it's a healthcare intervention. We're treating a health condition, and we need to treat it like a health condition, and not a social disorder. We're treating a health condition, and it's a chronic health condition. And we as treatment providers need to stop discharging clients when they exhibit their symptoms, which means when they return to drug use, because that's why they came to us in the first place. We would hope that our cardiologist doesn't kick you off their treatment panel because you had a heart attack. But that's what treatment does, right? People use drugs and they kick you out of it. So while we have to maintain safe and drug-free facilities, we have to also find a way to move people, to retain people in care, really at all costs. Because when we don't, the people that we serve have such high risks for contracting life-changing chronic illnesses that could kill them, for dying of overdoses, for ending up either committing crime or ending up in prison. The disruptions to their life are enormous. And so, we really do need to practice. I feel strongly, we really do need to practice an approach that sees that we're treating a complicated chronic health condition, and that sometimes it is marked by people exhibiting their symptoms.
Yeah, I'd just like to add to those comments, because I think this is a critical thing, and it's been something we have talked about here at SAPC for the last several years. I mean, when you look at the history of substance use, and all you're aware of this, that have been working in the field, is there was a time when, if you used drugs, you were kicked out of the program. I mean, which makes absolutely no sense. And I think that, one of the issues, and I think Don's term is right, we're really trying to talk about being patient-centered, because I think the issue is that harm reduction has been very much associated with substance use. And it really goes back to when we started needle exchanges for heroin users, and that the idea that was you were reducing harm, and people see that as, you're just allowing people to continue to use drugs. So as we move to the idea that substance use is a chronic disease, we also need to treat it as a chronic disease. So I would like to get rid of the harm reduction idea as we move into the medical model, which, there's a behavioral component to substance use, and we also know there's a biophysiological, and Gary can certainly talk to that piece of it. But they come together, and we need to work in unison with it. But I think this idea that, the time when someone needs you the most is when you would kick them out of treatment makes absolutely no sense. So again, use the cardiac, someone's hemoglobin A1C is out of control. You don't say, you've relapsed, we don't want anything to do with you. It just makes absolutely no sense. That's the time when you want to bring them in and make sure that you get it under control. So, and again, I think that's one of the things that we talked about earlier in the waiver, which I've been a big supporter of, was the whole recovery support services, that you can bring people back, you can check in on them. They're not cured the day they leave the program, they have a chronic disease. And I think as part of a treatment plan, you guys are gonna have to decide based on that individual, should they come back and see me a week after they leave? Should they come back and see me 2 weeks later? Or can they come back and see me a month from now? But again, there's going to be some clinical judgment here, just as any physician would make a clinical judgment about someone who is a diabetic or asthma when they need to see them again the next time. Or it may be a 1-year check-in, as you go to your physician every year and have a checkup every year. I don't see why this can't be part of it, because it's a chronic disease, it's ongoing, and we need to treat it as that. So, if we can't just say the words and then act differently. But I think this is part of becoming part of the healthcare delivery system too, is that as we do that, we start to look at substance use as a healthcare problem and not a criminal justice problem or a moral problem or whatever. So we have a long ways to go, and I think all of you in the field know that, but we're on that road now, and I think that's part of what's very exciting about everything that we're doing right now.
So just one more comment about that. San Francisco is convening a task force to explore safer injection facilities, which we've been advocating for as well. And these are facilities where IV drug users inject drugs under supervision of an RN in a sterile environment. And so we're in support of that. First one in the country is about to be opened in Seattle. It's a model that's been used in Vancouver for a long time. It reduces the spread of infectious diseases, reduces the death of opioid overdose, also takes reduces the number of people who inject drugs out on the street, which, in San Francisco, the 10 to 1, I think it's Skid Row, probably here as well. You have people injecting drugs on the street. So we've been advocating for that as well. And a number of people move from when there's no shame or judgment associated with it, people are more likely to move from injecting drugs in a safer injection facility to potentially engaging in care.
If I could just add a couple more points. So number one, I think we've learned today that Wes and I are probably the most talkative microphone distributors and moderators that you'll come across. But to the question about harm reduction, harm reduction looks like a lot of different things to different people, right? And I very much agree with everything that's been said by the panelists. Just to give a concrete example, we know that everyone's path to recovery looks different. Some people are more ready for recovery than others. And so if the choice that we have in terms of having that take a more patient-centered approach, if the choice that we have is to engage someone in treatment, even though they're saying, you know what, I'm not quite ready to stop. I do want to decrease use though, because this is causing a lot of problems. And I think if I just at least cut my drug use in half, that at least alleviates some of it. If the choice for that individual is, well, come back when you're ready, or, well, let's continue to have conversations and come back next week so we can talk about this, right? The patient-centered approach that we think is better is to engage that individual, right? To move away from the all or none approach to, the engagement approach. The other thing about harm reduction is also, like I said before, people define it differently. Oftentimes, harm reduction is grouped with medication-assisted treatment. I'd like to see us move away from that, just because medication-assisted treatment is an FDA-approved medication for a specific purpose, right, for addiction. And to group those FDA-approved medications as harm reduction, to me, sends the wrong message. And so, but the traditional, I think, way that people refer to harm reduction would include medication-assisted treatment. So to get to your question, how does the waiver impact that? As was discussed, the waiver will offer greater access to medication-assisted treatment. So that's certainly, I think, going to be beneficial moving forward.